Hello, sorry about the slight delay. We've just had a small little technical difficulty, but we are, in terms of putting onto another link, but we are working on this now. I just want to thank everyone for their patience at this time. So I'm just going to, it looks like we've got everyone in. Okay. Thank you so much to everyone that is attending today. I am so happy that we have been able to do this webinar today. I think it's a webinar that everyone, or a topic that everyone knows about, but we don't talk about it very much. And I'm so thankful that we have Tari and Tashani here talking about budgeting Australian guidelines, and they're going to be talking about some tips and some lessons that they've learned in their experience. So just to first acknowledge the traditional owners of country throughout Australia. I'd like to acknowledge the traditional owners of the Kaurna land, as I am in Adelaide, and I'd like to also pay our respects to elders past and present. So, as I said, we've got, thank you so much for coming. I just want to point out a few key features. You are able to chat. If you did want to talk, I can easily allow that to happen as well. And if you have any feedback, please send it to ANZ GIN, the email, and a recording of this will become available on the GIN YouTube channel. If you are on Twitter, or X as we now call it, please connect to our X account and we will be able to respond and contact you as well. But we love to be able to share the love. So I am extremely happy to be able to have Professor Tari Turner and to have Dr. Tashani Zazaran here today. They are from ALEC, Australia's leading guidelines. If I can get you both to put on your cameras, if you can.
I don't seem to have that option.
No,
Danielle.
me neither.
Remote, I can do this. Oh goodness. Yep, I think I've now given you the ability to Shani.
Yep, thank you.
And I think I've now done that to you as well, Tari. Excellent. Perfect. So thank you so much for being so grateful in doing this presentation for us. I cannot thank you enough. Tari, you mentioned this on a whim, and I then took that opportunity. So thank you. And I'm going to hand over the reins to you both because I think you've just got a wealth of information to share to our community. So thank you.
Thanks, Danielle, and hi, everyone. Give me literally 2 clicks while I share my screen. And I'm hoping that you're seeing the right thing there now. Great. Thanks so much for giving us the opportunity to talk about budgeting for guidelines. I think if you'd told me 5 years ago I'd be leading a GIN ANZ webinar on budgeting for guidelines, I might have been quite surprised, but we've done quite a bit in this space recently. So I'm very glad to have the opportunity to chat with you, and particularly delighted that Tashani's here to answer all the hard questions. So hi, I'm Tari Turner. I'm the Director of the Australian Living Evidence Collaboration, and I'm based on Boonwurrung country out on the outer east of Naarm down here in Melbourne. And I pay my respects to the elders of this country. It's a beautiful land, and I recognise that it's unceded and that they have an ongoing connection to land, sky and water in this region. Extend that respects to other Aboriginal and Torres Strait Islander people who might be with us today. Tashani, do you want to acknowledge the elders in your country?
Yes, thanks, Tari. So I'm up on the mid-north coast, and so I would like to pay respects to the Beer Bay people up on the mid-north coast here in New South Wales, and pay my respects to the elders past, present and emerging.
Great, thank you. So our plan for this session is to do a little bit of backgrounding on who we are at the Australian Living Evidence Collaboration, our approach and experience, so you get a sense of where we're budgeting from and the kind of work that we're budgeting for and what we're thinking about when we think about budgeting. And then we're going to just explain the way we think about budgeting in these 5 big buckets. So evidence synthesis work, convening work, communications, business management, and evaluation. And then we'll have an open time for questions, and we really think that's the most important part. So forgive me if we spend a few minutes just talking a bit about ourselves, but I do want to give you some background. So for those of you who haven't met the Australian Living Evidence Collaboration, I'm going to say ALEC from now on because that's far too much of a mouthful to keep repeating. ALEC is a collaboration of 64 health professional member organisations representing essentially the breadth of the health sector in Australia. So most of the professional colleges are members of ours, along with consumer organisations and other health sector groups. We're independent and don't take any money from pharma or anybody else who might be able to influence our recommendations. We're funded by Commonwealth and state governments and philanthropy, and we're based at the School of Public Health and Preventive Medicine at Monash Uni. And I might just get Tishani to stick our website URL in the chat while I move on to the next slide. So this is the crew that I'm talking about, and the work that I'm talking about us budgeting for is inevitably done by these guys, many of whom will be familiar to you. And our approach is very collaborative. We aim to engage broadly, to respond to need, and our internal motto is here to help. We really see ourselves as supporting clinical decision making in priority areas across Australia and across Australian health settings. So we do this via building collaborations, hence we have 64 member organisations, but also building collaborations around each of the pieces of work that we do, involving clinicians, consumers or people with lived experience, policymakers, health organisations and researchers in all our work. And our fundamental job is around developing living guidelines, although we also do other forms of living evidence synthesis. And we have a big influence on communicating and disseminating our work. And we want to keep getting better at what we do. So we conduct research alongside our guideline work to improve our impact. Some of you will have seen this diagram before. And I'll just pause for a moment to talk about the difference between living guidelines and traditional guidelines. And you know, over the last 3 or 4 years, really, there's been a big uptake in this idea of living guidelines. But just so that when we're talking about the same things. Every guidelines program should at least start with the same kind of basic approach, that we develop the scope for the guidelines, outline the clinical areas that the guideline is going to address, the clinical questions that are within that scope, search for evidence to underpin those, research those recommendations, convene your panels to discuss and interpret that, develop recommendations, draft those recommendations, and then publish the guideline. And so we refer to this as climbing the mountain. In any guidelines project, whether it's living or otherwise, the guideline goes through this same process to reach a high quality product that's published. In a traditional guideline program, many of you will be very aware that the approach has really been that guidelines are not regularly updated. They might be updated every 3 to 5 years, they might not. And so after that publication process, really a traditional guideline loses reliability over time as new research is published, as the clinical environment changes, as new drugs become available, etc. So the difference between a traditional guideline and a living guideline is that once we've climbed that mountain, we then maintain the processes that underpin guideline development. We continue to search for new evidence, we continue to convene our panels, we update the guidelines in a continual fashion. But in terms of the budgeting, today our focus is going to be on this piece at the beginning of climbing the mountain, which is consistent across a traditional or a living guideline model. Maybe it's a conversation for another day, Danielle, to talk about budgeting for this ongoing process. We've now had a few guidelines, living guidelines that have been established for a long time, stroke guidelines, which are 6 years old, for example, the COVID guidelines, which were established for 3 years, and we've got a little bit more information about what's required to budget for this phase. But today I really want to focus on this part. So just to give you a bit of context for us, the grey hairs that you can see on my video are the response to 20 years of developing guidelines in Australia and overseas, developing guidelines that are recognised by NHMRC and WHO, meet those standards. We're based at Cochrane, as I mentioned, and we sit alongside our sister, the Melbourne Grade Centre, recognise their expertise, for which we're very grateful. I've already mentioned a couple of living guidelines that we've been involved in. So The Stroke Foundation guidelines, which were established in 2018, which were the world's very first living guidelines, and many of you on the call who are leading work around living guidelines in diabetes, arthritis, kidney disease. During the pandemic, we established the National Clinical Effectiveness Task Force COVID-19 guidelines, and more recently, we've picked up pregnancy care and postnatal care guidelines, and I'm going to talk about those later too in just a moment. I'm not going to go through the detail of this, but just to give you a sense that we follow the internationally recognised rigorous grade methods for developing our guidelines that meet NHMRC standards and that do all the things that you'd be familiar with, ensuring that we have clinical and consumer input, that the guidelines are firmly evidence-based. Things that might be a little bit different for us. So we use a steering committee model, which means that we have dozens of organisations involved in endorsing our recommendations, and we publish them in Magic App, which is obviously an important question for budget for us. And if you'd like to know a little bit more about our model for developing living guidelines in particular, you can find information in our Living Guidelines Handbook, which you can follow this link to, or click on the link that Tashani had already put in the chat. So just to give you a bit of a sense of what this looks like in practice, some of you will be familiar with our COVID-19 guidelines. So these were funded from 2020 to 2023. Some of us have blanked out that period for a whole range of different reasons, but we were quite busy. So over that period, the guidelines grew to have more than 200 recommendations. They were updated more than 120 times, so those little cycles. We were running daily searches and weekly updates of those guidelines, which is not something I would ever recommend we do again, but was quite an exercise at the time. We involved more than 250 clinicians and consumers, ran more than 10 panels on different areas of COVID care, so pregnancy care, paediatric care, but also primary care and acute and critical care. And those guidelines were endorsed by 35 organisations. Because of the focus on comms that I'll talk a bit about when we get to the budgeting section, those guidelines were very widely disseminated, and we had hundreds of thousands of people using them across the globe, actually, including almost 1.5 million page views and also the use of our dissemination tools like the flowcharts. I won't dwell on this slide because, as I said, some of us still have pandemic PTSD, but just to flag too that this grey here is our guideline traffic to our website, and the red in the background is the COVID numbers, hospitalisations. So we could see that the guidelines usage was tracking with COVID hospitalisations, which was quite fascinating. A more recent piece of work for us, what we refer to as the LEAP guidelines. These are living evidence-based guidelines for postnatal care and pregnancy care, established last year. And we're taking the existing pregnancy care guidelines, transitioning those to living mode, and establishing new postnatal care guidelines. This has been done as a partnership with ACM and RANZCO, the College of Midwives and the College of ONG, in collaboration with 24 other organisations, and that's work that's currently underway. So to get to the pointy bit of what we were here to discuss, we're going to talk a little bit about the core costs, skills and tools and considerations that we take into our thinking about budgeting, whether it be for the COVID guidelines or the more recent pregnancy and postnatal care or other guideline programs. And when Tashani and I were talking about this, it kind of feels like it falls into 5 buckets for us. So there's clearly a piece, and I speak as an evidence methodologist, around systematic review, evidence synthesis and methods, making sure that we can do the work of the systematic reviews that underpin all the guideline recommendations really well and reliably. That's a core area for us. We also have a big focus, as I've mentioned, on collaboration. So ensuring that we invest in convening, having all the right clinical and lived experience expertise at the table, but also having the right stakeholders in the room. The comms piece and making sure the guidelines are translated, and all the things that sit around that make it actually feasible, all the HR, logistics, operations, finances, contracts, budget, all that kind of stuff. Then you'll notice a big gap, which is where in theory you would be funded to do implementation of the guidelines. Sadly, that's an area that's really not well funded, at least in my experience, and maybe if somebody else has had more success, then we could talk about them writing a webinar on that. And then the process and impact evaluation. And this is really how I got involved in guidelines in the beginning. And so it's a passion area for me. And we'll talk about each of those in a bit more detail. So starting with the top, or maybe it's the bottom, the fundamentals, the underpinning. The core costs for us in terms of systematic review and evidence synthesis are really where we start to think about this thing. So obviously, driving that are evidence officers, information specialists, and shout out to information specialists. And I strongly encourage you to invest in getting somebody awesome like Steve McDonald to run your searches. It'll save you tons of money down the track. Core tools. For us, we use Covenants for all our screening and those early parts of the evidence synthesis process. We also use RevMan for analysis pieces and so on. So thinking really clearly, I think, at this stage about who you need and what tools they'll need to have in their hands to do a good job. Shani, do you want to have a chat about some parts of this?
Yeah, sure.
Perspective? Oops, sorry.
All good.
There we go.
So yes, Sarah's always talked there about staff and tools that they will need to do their job. And so essentially what we start thinking about is how big is the guideline going to be? So scope is, you know, for everyone who's ever written a guideline, one of the key components to think about. But it's also especially important in terms of how many people you're going to need. Is it a new guideline, i.e. you're starting from kind of very little, or is it an update and therefore there's already existing information? And also about your methods. So in terms of the number of people you might have, so we do double screening of things. And so we always require 2 people at least who are involved in the screening process. And so there's some things there to think about in terms of how the scope and the number of questions and the existing evidence sources that already exist in the space might impact upon what you're doing, but also specifically, you know, the methods that you choose and therefore how many people you might need in order to kind of get through that job as quickly as possible. And also important in that is what are the time constraints? So depending on who's funding the guideline development, they may have particular timeframes in which they're looking for, and that can be for a whole range of different reasons. Can be because of external pressures for them. It can be because there's a certain important event coming up, or otherwise that they would like to release it at. So there are some time constraints issues in place potentially, and that also impacts upon how much you're going to need in terms of resourcing to get things done by a certain time point. We also start thinking at this point about approaches to publication. So are we going to take a whole of guideline approach? So are you going to get all of your evidence together for all of the clinical questions and all of the work and then publish? Or are you going to publish as you go along, which is an approach that we often take within ALEC, which is that there are either individual topics or individual recommendations that are published at a time. So rather than waiting until we've done the entire mountain climb, we will put things up as we get through each of the different stages, but depending usually on prioritization. And so we do a lot of work in kind of the next section or the next couple of sections around convening and stakeholder engagement around what the topic order looks like if we're going to be rolling out like that. And then there's also a question around your mix of more senior or junior staff. And in reality, this comes a bit down to dollar figures and also complexity of the topic. Obviously, your more senior staff cost a little bit more in order to do the job. But obviously, they usually come with more experience, can often do things a little bit quicker, have, you know, different approaches and that sort of thing. And so there is an element there about what is the appropriate mix of your kind of more junior to senior evidence role staff. And then we also need to think about beyond the people who are doing your evidence synthesis itself, what else might you need in terms of people and in terms of particular experience or skills. And so for us, often that might be in the biostatistician space, especially if we're going to be doing some form of particular analysis. It might also be in qualitative. I mean, we're quite lucky within the ALEC team that the qualitative stuff is, you know, pretty well covered in terms of experience, but that might be something that you need to think about depending on the topic area and the types of evidence that might be available. And often right at the start when we're doing the scoping of the guidelines, we do a quick little search we will do an update kind of little search about, so that we can have a bit of an idea about what we think the amount of evidence might be up front, so that we can have that as a bit of a plan of attack for how we might determine how many people we might meet, or the sorts of people we might need in order to get the systematic review and evidence synthesis work done.
Great, thanks, Shani. I think the other thing to think about at this really early stage, Shani touched on scope. Of course, that's a driving factor in decisions around how many people you'll need to do the work, but scope never, ever gets smaller over time. So the scope that's described in whatever is the request for quotation or the tender or the grant application will always increase. I have literally never been on a guideline where scope decreased over time. So making sure that's part of your budgeting from the beginning. The second piece for us is around convening and stakeholder relations. So how we bring in all the other expertise beyond the evidence that's needed to make sure that the guideline is robust and reliable, and also that it's has credibility and is trusted by the people who are going to use it. So for us, we think about 3 levels of engagement. So a clinical engagement, and that means for us clinical panels and chairs of those panels. We also employ clinical fellows, so small fractional employment for people who have very specific expertise in the guidelines that we're working with. So in the context of, for example, the LEAP guidelines, we have magnificent clinical fellows, Zoe Bradfield and Nisha Cott, who give us a small number of hours per week. That means that we can ask them all the dumb questions before we go to our panels. And that is absolutely worth doing if you can afford to do that. The next area for us is consumer engagement. And I cannot emphasize enough how important it is to have people with lived experience deeply involved in your guideline development program and to budget for that. So NHMRC standards require relatively limited consumer engagement, a couple of people on the guideline panel. But if you're going to invest anywhere in the process, I would strongly suggest you invest in a more substantive involvement of consumers in the process, and that you think about how you're going to do that in your budgeting. And also a person who is funding for a person to support those people to be a part of the process. Shout out to Annie Sinnott from the ALEC team, who is the guru of this from our perspective. We also think about support for policy engagement. So Sam Chakraborty within our crew leads up a process of engaging with policy actors at the jurisdictional and Commonwealth level. This is less about the guideline content, but more about the implementability of the guidelines, making sure we understand the policy context into which guideline recommendations will be going, get appropriate feedback and engagement as we develop those up. Shani, did you want to talk to some other things to consider?
Yes, some specifics around here. So at ALEC, we choose not to pay our clinicians who are on panels. That's part of our process. So we often do get asked about this, but in fact, the way we've set up our panels and the way we choose to do things is that those are a largely volunteer role. And so that includes kind of the panels that we have. So for instance, in those 10 panels that Tari talked about for COVID, or in pregnancy and postnatal, we have a pregnancy panel and a postnatal panel. The clinicians on those, as well as on our guideline leadership group, don't get remunerated for their time. And neither do the members of SteerCo. So the SteerCo is the organisational kind of level, and they do the unanimous endorsement of any of the recommendations that are put forward through the panel process. But we don't pay any of those groups. Who we do choose to pay is consumers, to ensure that we're appropriately remunerating their time and their experience and their knowledge that they're bringing to this. Most of the time, clinicians are doing it in work time, and so therefore they're kind of otherwise already being remunerated for that time. Whereas obviously for many of our consumers, our people with lived experience, that is not the case. Annie Sinnott, who Tari mentioned before, did quite a significant amount of work a couple of years ago around trying to work out what the most appropriate amount is to pay for consumer time. And so, you know, she's come up with a way and approach by looking at various different groups, government agencies, kind of colleges, other groups, how they've done it, and we've kind of come out with a pay rate per meeting for our consumers. And then if they're the way the consumer panel works is that there are, generally speaking, somewhere between 12 and 16 members on our panels, of which 2 will be deputy chairs and 2 will be chairs. And so we essentially have kind of a 4-person kind of leadership of that group. So they get paid a little bit more for the extra time. They often have a bit more reading to do. They have a bit more activity prior to meetings. And so they have a slightly higher rate than our other members. And we have started indexing that on an annual basis, recognising that a standard rate 3 years ago is probably not appropriate now, given cost of living expenses and other things. So we have started to build in an indexing percentage every year into our future budgets to kind of account for that as well. In terms of thinking about that, so obviously the way we've got ours set up, we have panels, we have guideline leadership group, and we have steerco. There's a lot of organisation of all of that. So who is setting up your meetings, preparing your agendas, doing your minutes, doing any of the other documentation that's required? So there's some thinking there about who's going to kind of do all of that organising. And so we actually include that in one of our later costs, but it's something to think about at this point when you're thinking about what your panel structure is going to be like. And the way ours work, in fact, the consumer part is fundamental. We start all of our panel, our sets of panels with the consumers. So they get the first look at the evidence that's developed by the evidence team. And then they actually follow it through. So those deputy chairs and chairs follow that through to pregnancy or postnatal panel, through to guideline leadership group, through to steerco. And so it fundamentally allows kind of their input the whole way through. And they do get paid for each of those meetings, just so you're aware. And we also have Annie involved, obviously. So we have a consumer support person who's on with us and a fractional appointment. And that is fundamentally important. It helps support consumer involvement. But we also need to help clinicians in their involvement as well. So there is training in grade methods. There are a whole range of other things that happen in the background to ensure that everyone is on the same page when it comes to what the evidence there is that they're looking at and what that means. And so there's some thinking there about who's going to be doing that as part of the kind of core costs and how we do our stakeholder engagement. And obviously, whenever we're trying to put together these panels and these groups, we're always thinking about equity, diversity, and inclusion. So have we got the right mix? Are we covering the scope of the guideline in terms of clinician and in terms of consumers? Are we covering different experiences, different places, different settings that things might occur in, et cetera? So those are all important considerations that for us, because we meet via Zoom, there isn't an additional cost necessarily associated with different places that people are or otherwise, but it's certainly something that could be considered if you're thinking about face-to-face interactions or otherwise.
Yeah, agreed. And I think too, it does mean that we have to build into our timelines and therefore our budget extra processes for expressions of interest and ensuring that we can recruit people with all those equity and diversity characteristics that are really important to a good guideline. The third area for us is comms and knowledge translation, and I've always known that comms is really important, but post our COVID experience, I'm a massive evangelist for investing in comms. So for us, we think about this at three levels. One is stakeholder engagement at the organisational level. So I mentioned a couple of times that we build these broad collaborations of health sector organisations, and our steerco that Tashani has described consists of representatives of all those key organisations, and maintaining those relationships is priority for us. And that means we need somebody with senior stakeholder engagement skills who has lots of mobile phone credit to call them and make sure that we're meeting their needs and that they understand what's going on. The other comms activities are probably kind of more classic comms. So we build a website, we maintain it, and we pay awesome graphic designers to do logos and the kinds of things that you forget about, but that cost you money. Got summary guideline formats, flowcharts, those kinds of things. Kayla and Shauna do awesome work around news articles, making sure that the story is getting out about these things. And that's both as part of the guideline process. So NHMRC requires a 30-day public consultation period, but also more generally, because our guidelines are continually developed, we have ongoing comms throughout the process to build awareness that the guidelines are being developed and then are available, and then to ensure that we're revising and keeping people up to date as they change. We do have to factor in expenses for Magic App, the publication platform that we use, and that is absolutely an additional cost. We also have a focus around dissemination, so comms for newsletters, for social media. We're on LinkedIn and X, and we also prepare comms packs for our partner organisations so that they can, whatever the right word is for tweet on X, I still haven't worked that out yet, post, I think, or share with their LinkedIn profiles through their members and so on. We would love to be doing more work around co-designing this part of the process and really engaging well, and that's an area that we're looking for doing more funding in. During COVID, we were able to have great media engagement because it was such a high-profile issue, and that's something that was absolutely part of the high user numbers we got, for sure. And then some words that I'm less confident about, so please don't ask me any questions, but we pay for things like Sprout Social and other social media platform tools, and that graphic design that I mentioned before.
So if you're wondering about Sprout Social, it essentially enables you to kind of make one post but have it in formats for multiple platforms. And so it kind of adjusts it for the appropriate platform that you're going to send it out to, so that you can kind of have it go out in a variety of formats.
And that's work that Kayla and Carly lead for us. So thanks to them for doing that, because as you can tell, it wouldn't be I wouldn't be doing it well. The fourth area is our, these kind of program business management piece. So clearly none of what we've previously described happens unless we've got the senior oversight and admin support. So these are the pieces of work that are around project management and designing and ensuring that you keep to budget, managing HR, contract, finances, all those things. And so ideally in each of our programs, we're building in small fractions of work for part of my time as academic director, part of Steve McLaughlin's time as our clinical director, part of the magnificent Miranda Compson's time as our guidelines program manager, and Shani's time. Obviously, you can see why we need to make sure we pay for her, and also for research support. So none of our single guideline programs could support these people, but we try to build in fractions where it makes sense within to ensure that we can make the process sustainable.
Yeah, and I think I would just say these are often the hidden costs. Like you're often quite likely to remember most of the other things that you need to do, but often these are quite hidden. And because we are within a university sector, there are a lot of requirements on us around many of these things, but they are often hidden. And there's things about reporting, for instance, that you don't necessarily think about. You will have reporting requirements to whomever is funding you. So somebody needs to be available to do that additional work. And so that probably isn't your evidence officers. So you need you need people at other levels to be able to do some of those project management related things and to meet deliverable requirements, etc. And so, yeah, I would say often forgotten, but fundamentally important to kind of keep things going in terms of guideline development and making sure you're meeting all of your requirements.
Completely agree. So in between this slide and the next slide is a black box of implementation. So we're not going to talk about that today, but we'll move on to evaluation, but I don't want to pretend that guidelines implement themselves. But for us, there's two elements to the evaluation component. And the first bit is the bit that I'm really passionate about, and I think particularly in a living guideline space, we should be doing all the time. So by process evaluation, I mean an evaluation that sits alongside the guideline development process. And Tanya Millard from our crew leads up this work for us. And that's really about understanding what's happening in the guideline development, what's working, what's not working, what can be improved, and how can we improve the quality of the guideline, but also the quality of the process as we go along. So this is something that, as I mentioned, I think living guidelines models really support very well, because you can improve your methods and change your approach over time in response to feedback. And if you ever have the opportunity to build this in, I would strongly encourage you to do so. So as I mentioned, we have Tanya Millard who leads this up for us, and she has that evaluator skill set combining both qual and quant skills. And so she conducts interviews, but also does surveys with our evidence team, with our wider guideline program team, but also with all our stakeholders. And that requires funding, obviously, for her time and for some support for her, but also survey tools. We use Qualtrics, interview transcription. We aim to do online transcription where we can get ethics approval for that and the analysis to do that work. And then access to data. So data like web analytics, whether that's Google Analytics access or process data in terms of number of studies screened, number of recommendations updated, level of input that you're getting from stakeholders, those kinds of things. And then I think too, the evaluation, the impact evaluation is really important for telling the whole story. So being able to say, this is the work that we did and this is the impact it had, then allows you to obviously get the next chunk of funding that allows you to do more work. So thinking about impact evaluation and being able to demonstrate the impact that your guideline has had on the process of care, ideally health outcomes, but there's a whole lot we could unpack. That's probably a webinar series in itself. But in thinking about impact evaluation, again, thinking about the evaluator, but potentially some other specialist skills. Health economists are a really important part of this conversation. Biostatisticians, absolutely necessary if you want to do this in a rigorous way. And similarly, tools around survey, interview, analysis, but probably kind of level up on the process evaluation approach. And then access to other types of data. So registry data is ideal here, but other forms of data too. Anything to add, Shani?
I was only going to say, it is also a nice starting point. We don't have it here. If there is or could be a baseline evaluation, if there is an existing guideline already in play. We don't have it on this slide, but that is fundamentally important and ideally well-funded, often forgotten, but is great when you can do some baseline evaluation of existing guidelines.
Yeah, that's a really good point. You're right, and I should have mentioned it earlier, quite right. So we've been fortunate in a couple of situations where we've been funded to do a guideline development, and we've been able to say to the funder, you know what would be really awesome if we could do a baseline evaluation before we started the guideline development process, because then when we come and do the evaluation at the end, we actually have something to compare to. So yeah, agree, that's a really important step if you can build it in early in the process. And it's a real pain to get to the end and not have a comparison to be able to compare back to. A few closing thoughts. I mean, I think the first one speaks for itself. It's really easy to do this badly. And if you don't have the budget, you will be in a position where you can't do it well. And that's really, really an unpleasant place to be. So I think setting out from the beginning to work out what's required to do it well, given that what gets us out of bed is having an impact on people's health and their health care, making sure that you develop a guideline that you're pleased to stand behind and feel comfortable is rigorous and reliable and should be used to make care decisions, budget to do it well. I mentioned already, scope never gets smaller, like literally never. So budget with a reasonable expectation that scope will creep over time. I mentioned before too, investing in comms is absolutely crucial for impact. And I do live in fear of guidelines that are beautifully developed, but then sit on shelves, whether those be IKEA shelves or website-based shelves, in making sure that your budget invests in getting the guidelines out to the people who need them. Can't emphasize enough the importance of evaluating, and as Tashani was just highlighting, thinking about that from even before you begin your guideline development process. And I think I often have the thought in my head, what will future TARI wish I had put in this budget? It can be tempting to cut in a way that means that you're not in a position to deliver what you wish you could. So thinking about that is a useful guide from me. Any other reflections, Tashani?
I think maybe the bit we haven't touched on is where you're getting your money from. So obviously, as Tara mentioned at the start, we don't take money from industry. We largely, we are independent of industry. And guidelines are kind of funded in this country in not a magnificent way. They're quite bitsy, is the way I would kind of describe it. So some of it comes through grants, some of it, through research grants or otherwise. Some of it will come direct from colleges, some direct from government, depending on what it is that they're otherwise, kind of their priority areas are at the time. But it is rare to get an amount that you would love to get to do everything perfectly. And I will say we have said no in some instances where we didn't think that we would be able to make the kind of guideline that we would want to do, even though the topic area was of interest and interesting and otherwise, but there was just not enough money on the table. And part of the reason why we would say no is because we want to be able to do it well. And if we don't feel like the money available is going to enable that, we are not comfortable, but we will say not for us at this time, really sorry, because we know all of the bits that help make it be the best guideline it can be in terms of the evidence and the rigor, and then the bit that actually helps it be implementable and useful. And so we don't like to, you know, for us, you know, I guess we're in a fortunate position to be able to say no. That is not always the case that people are in. But certainly, you know, I think it's important to think about who the money's coming from, what their expectations are, and how involved they are going to be in the process. I think, you know, that's not necessarily budget related, but it is still fundamentally important to what it is that you're able to achieve with what the budget you have.
Yeah, completely agree, Shani. Thanks. That's all our slides, Danielle, but we'd love to have a conversation. Happy to answer any questions, so I'll stop sharing.
Thank you so much. That was a wealth of information, and I think many of us probably hadn't thought as in depth of what actually needs to be put in a budget. Now, please, everyone, put in your questions either in the chat. I believe that is now enabled. If not, put it in the Q&A. We would love to be able to talk. Whilst I'm waiting for those to come in, I just want to know how you have discussions with funders who may undervalue guidelines. And do you, and I know, Tashani, you said we've said no, but, you know, sometimes when you're having those discussions, what are those types of things do you mention?
Yeah, I mean, I think that's a really good question, Danielle, and there's certainly a place for saying to a funder, we understand your bucket is X number of dollars. For that number of dollars, we can do these bits, but we can't do all of those bits. Like laying it out, this is the, you know, with that money, we can do this, but if you gave us this extra money, we could do all of that. I think too, we often get, like we've done in the last week, had this conversation where we're like, okay, so that's how many questions, that's how many systematic reviews, we've done a brief look around, as Tashani said, we've identified that would mean we would need to screen X 100,000 studies, and that would take, you know, like because people who haven't done the evidence synthesis piece don't understand that just because you don't think there's any evidence doesn't mean you don't have to screen a whole lot of evidence to be sure that there is no evidence. Being really kind of nuts and bolts about that, we could do that, but that would be 17 weeks of evidence synthesis time. Is that really what you think is the most useful place? And then having a conversation, maybe you don't, maybe actually funder might decide that diagnosis isn't as important and they just want to do treatment. That might be one way of talking about scope or just those kinds of things. But I think being really concrete about what it takes to do the work that's being asked.
Yeah, I just want to second that. A lot of funders do not recognise the amount of work that is sitting in the background to get to the point of having a guideline, all of that evidence synthesis activity. And so they don't necessarily understand how much work it is and therefore how much time it will take. And therefore, you know, we're quite honest. Like we go, okay, we estimate it's going to take this amount of time, therefore it's this amount of money. Is that where you want to spend what you have, or, you know, or we suggest something else potentially. So, you know, we try and have a pretty frank conversation really about what is and isn't possible within what budget they have. And, you know, sometimes that means that they'll go elsewhere. Sometimes that means they'll come to the party, or we'll just do certain bits of it. It's a little bit dependent upon who the funder is and how much flexibility they have themselves. Less so with government. They often have a very tight, very regimented budget. But, you know, other groups may have a bit more flexibility in terms of, you know, what they can spend and how they can spend it. So, yeah, we just try and give them as much information as we can to have those conversations.
Yeah, I think that's right. And maybe the only thing to add would be Tashani's point about making the case for evaluation. The people who are funding guidelines often also want to be able to tell the story about the impact of their funding. Mm-hmm. So being able to explain to the funder that why it's important to them to have done a baseline and to be able to do the post development assessment, I think they can tell that story to the people that have given them the money. So I think that's a useful part of the conversation too.
I think that's some very wise words. I've got more questions, but we've got one in the question and answers. Aline says, what are the indicators that you would normally include for process evaluation? Is it mainly on knowledge gap?
Hi, Aline. So for us, process evaluation is not about the knowledge gap. So the knowledge gap is definitely part of the underpinning reason to do a guideline, clearly. But when we're talking about process evaluation, it's very much around quality improvement in the process of developing the guideline. So we do have indicators that are around the workloads for the teams, the amount of evidence that's being screened, the amount of included studies, the number of recommendations. And we have indicators that are around use of the guidelines, so the number of people who are accessing our website, accessing our Magic app, those kinds of things. But most of the indicators are around the process. So how are people, we work with our consumers, for example, about, how engaged are they feeling, what's working for them in terms of the way that we're communicating with them, how could we better support their involvement, and the same for our clinical panel members. How they're finding the meetings, do they have enough time, is there enough content, would they like additional information, and also with, we do the same with our team, what's working from our work processes, how could we improve, is this, what are things we could be doing differently. So for us, the process evaluation is mostly around literally how do we improve the process of developing the guidelines.
Tashani, do you have anything to add?
No, I mean, other than where we would put the knowledge gain is the impact evaluation. That for us is where that, those kind of indicators would sit. One of the more difficult things to measure. So yep. It's a challenge. The impact evaluation, while fundamentally important, it's a challenge to decide what you're going to measure, how you're going to measure it, and what is it actually telling you. So there's a lot of thinking that needs to go into that.
Yeah, that's true. And there's multiple layers of that evaluation piece too. So there's kind of a piece that we do, which is around assessing what we call awareness, value, and use. So do people know the guidelines exist? Do they think they're a good thing? Are they using them? There's that kind of piece, which is reasonably straightforward. But the piece of the evaluation, which is about impact on healthcare delivery and changes on health outcomes, is kind of a whole other layer on top of that.
Yeah, and as Tara mentioned when she was talking, in the ideal scenario, you would have a guideline and recommendations that are very clearly linked to registry-based data around that particular issue, so that you could show pre and post implementation of a particular recommendation, whether there was change or not in terms of health service delivery or health outcomes or otherwise. There are very few examples of where that actually exists in the Australian healthcare system, unfortunately, but that would be the ideal kind of scenario for us.
Yeah, holy grail.
So you mentioned that funding in Australia for guidelines, and this is, I think, a bit of a hot topic for many of us, is trying to just get little pieces here and there. How do you think the Australian funding system needs to change to be able to support guidelines?
Oh, Danielle, big question. I mean, I think Shani used the phrase piecemeal, and I think that's quite kind. I think for me, ideal would look like national infrastructure that enabled prioritization of areas where there were, as Alina's suggesting, knowledge gaps, and that clearly we needed new guidelines. And for us, it's particularly about areas where there's clinically important areas where there's current uncertainty and new evidence is emerging. We really need a national approach to say, okay, well, for these really important priority areas, we need a platform that allows us to continually keep these guidelines up to date, ensuring that clinicians have the access to up-to-date guidelines whenever they need them. I think at the moment, yes, and we need the platform which goes right from prioritising, identifying what those things are, to convening, doing the evidence synthesis, developing the guideline, getting it out there, communicating it, disseminating it, implementing it, and evaluating it. I think we need a platform that is nationwide, does that in a systematic and systemic way, and that's funded appropriately to do that. I said Holy Grail before for the evaluation, so I don't know what the next kind of level up on Holy Grail is, but I think right now really unfortunate. There's a lot of people developing what they refer to as guidelines, but that probably wouldn't meet, that certainly wouldn't meet NHMEC standards and wouldn't really meet other standards for guideline development. And that in itself is a bit problematic. We get a lot of things that are not all that rigorous, not all that relevant, not all that reliable, not all that helpful, being tarred with the same brush. Everything's a guideline.
It's diluting the importance of clinical guidelines in clinical decision making, and that's problematic. And there is no great answer to how we fix that at this point in time. Other than all of us kind of singing the same tune, I think, to government, to our policymakers. I mean, part of the reason why it's important for us to have policy engagement as part of what we're doing in our guidelines is not only the bit that Tari talked about when she talked about it, which is, you know, how would this particular guideline be impacted or impact you know, existing policy or future policy that's coming into place, but also that engagement of people within government and who are making decisions about where future money might go or future priorities might be, having them engaged in the process of developing guidelines and understanding what's actually involved in development of an excellent, you know, really rigorous guideline is really important in kind of lifting the view of guidelines. And I think that ultimately is a good thing in terms of ensuring that we can get hopefully a little bit less piecemeal approach to funding of guidelines in the future.
I suspect there's others on the call, Danielle, who've got more experience than us in that world too. So it'd be great to hear what others think. I was wanting to ask, if I can, I know we've got a couple more minutes. I'd love people to put in the chat what they would like what area they wish had been better funded in their current guideline projects. I mean, I think for us, like, it's always, you know, I think we just had a bit more money for comms particularly, but lots of other areas as well. But I'm interested in what other people's experience is. Like, what's the area that other people wish they'd got funding to do better or do more of?
If you want to talk, I can, I think you can put your hand up as well, and I can allow that to happen as well. So either in the chat or form talking. I just hope everyone can access the chat. I know at one stage they couldn't. So if anyone can just put anything in the chat to make me feel like it's working. Anyone.
We certainly know the Q&A is working, so that's a thing.
That is the good thing. I know. Well, I'm going to mention one thing that I know is particularly problematic, and that is, I think, the value. People don't see the value, or they're now seeing it, but it has been a long time of seeing the value of consumer engagement and paying patients in particular to actually partake in guidelines, or actually in research in general. And I was mentioning before this, you know, I've been a patient partner now for 10 years, and I've seen this evolution occur. And so it is interesting to see now that there has been, we don't just need to involve them, but we need to pay, but then having to justify how much we pay is an interesting discussion of, you know, that's too much, that's too little. So, yeah.
Yeah, I totally agree, Danielle. And this is, for us, this is an absolute given. We will pay consumer / people with lived experience to be a part of our programs. That is a given. And we do have a structured approach for how we decide what that is. And I think it's a way that we respect that level of engagement and that involvement. So yeah, completely agree. And I'd love to see us elevating the role of consumers further in the guideline development processes, because this is, I mean, ultimately, they're the reason we do guidelines, and we want to support clinicians, but to ensure the best possible outcomes for consumers. So, yeah, completely agree. And it is, I agree with you too, that that does seem to be getting traction. Increasingly, that's the expectation, that consumers will be paid for their contributions, and that's appropriate.
Excellent. Okay, so thank you so much again, Tari and Tashani. I think this was an absolutely phenomenal webinar, a needed one as well. And I wanted to invite everyone to participate in the GIN ANZ regional group. We also have the ANZ Guideline Network, and to be able to, I think, as you said, come together, because, you know, being able to develop that holy grail can only occur with many voices, right? So if we have all of us speaking up about the need, I think we can hopefully move some direction forward. So I also wanted to say that if you wanted to continue chatting, we actually have a coffee chat for Gin ANZ scheduled at 11 a.m. Adelaide time on the 28th of August. We do have that on our socials that you can register for that. If not, I can send you the link. It's going to be informal discussions, but also just a chance to be able to network and just be able to meet anyone who's doing guidelines in Australia. So we don't feel so alone sometimes. So thank you so much again, Tari and Tashani. I cannot thank you enough, so I appreciate it. The chat is working, at least we knew that. But again, thank you everyone for attending. And as I said, this will be recorded and put on the Gin YouTube. So see you later. Thank you.
Thanks very much, Danielle.
Thanks.
Bye.
Bye.